Okay, it's time for the afternoon sessions. Are you ready? The first session is clonal hematopoiesis and inflammation. Unfortunately, Mario Cazzola is absent today. So the question is whether Ben Ebert will start first or he is the second. Because he's now at Boston, so we are not currently sure whether he is ready or not. So please wait. Maru, okay, he's ready. So the first speaker is Ben Ebert, Dana-Farber Cancer Institute, Boston. And okay, if he's ready, he can, okay. Now, Ben, can you start now?
Yes, I recorded my presentation and I'll take questions at the end.
Okay, so let's start. Your presentation, okay?
To speak here today, I very much wish I was in Kyoto with you, but I'm very honored to have the opportunity to talk to you today about clonal hematopoiesis and inflammation. These are my disclosures. The only relevant one is that we have some funding from Novartis, who makes an NLRP3 inflammasome inhibitor, and I'll talk about the NLRP3 inflammasome. Clonal hematopoiesis, I think, as everybody is well aware now, is a very common phenomenon in which somatic mutations occur in hematopoietic stem and progenitor cells, leading to large clonal expansions of cells in genes that are recurrently mutated in myeloid malignancies and that predispose to a number of diseases, including myeloid malignancies, including MDS, as well as non-malignant disease as well. Wanted to remind everybody that there are many different types of clonal hematopoiesis. CHIP and CCUS have now been defined by the WHO and International Consensus Conference as having a clone with a variant allele fraction of at least 2%. That's the number of mutant reads over the total reads, with a mutation that we know is recurrently found in myeloid malignancies, and that has normal blood counts, and CCUS, or clonal cytopenia of undetermined significance, is the same criteria with a cytopenia. That is separate from a somewhat separate technical field of mosaic copy number abnormalities, which are gains and losses of chromosomes that occur more commonly in lymphoid-oriented malignancies, but also in myeloid malignancies. There are lymphoid, both point mutations and copy number changes that are called lymphoid clonal hematopoiesis. There's an enormous number of individuals, essentially everybody with age, who has very small clones. So they do have clonal hematopoiesis, they do have small clones, but they don't meet the diagnostic definition of CHIP or CCUS. And then there are clones that don't have known drivers, which may be driven by an epigenetic change or an unknown driver, and that's often called clonal hematopoiesis with unknown drivers. The remainder of the talk will be just about CHIP and CCUS. So the first thing in defining this CHIP and CCUS is to distinguish it from the lymphoid abnormalities. And when we first looked at this, we really just were focused on myeloid genes, but when we've looked more closely in much larger data sets, we can see that there are recurrent mutations in genes that we know to be drivers of lymphoid malignancies. But it's much less common than the myeloid drivers, and there's no dominant mutations like DNMT3A, TET2, and ASXL1, which are so common on the myeloid side. However, both the myeloid and the lymphoid clones increase in prevalence with age quite dramatically. And as you might expect, individuals who have a myeloid mutation in their blood have an increased risk of developing a myeloid malignancy, as you can see on the left. And on the right, you can see that individuals with a lymphoid clone have an increased risk of developing a lymphoid malignancy. So, and if there's a myeloid mutation, that really doesn't affect the risk of a lymphoid mutation, vice versa. The copy number abnormalities, if anything, are more powerful in their risk. The myeloid copy number abnormalities, which are the ones that we know well from MDS, like 5q, 20q, 7q, when those are present, the risk of developing a myeloid malignancy is extremely high, about a 30-fold elevated risk. And when there are lymphoid copy number abnormalities, that dramatically increases the risk of a lymphoid malignancy. And most of those lymphoid malignancies are CLL or SLL, which are circulating lymphoid malignancies. The risk of a nodal lymphoma is lower, likely because those lymphomas don't have circulating precursor cells quite as frequently. And as we'll discuss later on, if you start to integrate other features like blood count abnormalities, the risks start to elevate quite dramatically. So a myeloid clone plus an abnormal CBC increases the risk of developing a myeloid malignancy quite dramatically. And in fact, an elevated lymphoid count in combination with a lymphoid clone increases the risk enormously, almost 1,000-fold. And one of the key exercises now is to identify data sets where we have both flow cytometry data and full phenotyping data for CLL to make sure that those individuals don't already have CLL, or do they have high count MBL, for example, that had not been diagnosed. So I wanted to focus on CHIP and inflammation, the topic of this session, and that initiated, at least for us, in our first story about clonal hematopoiesis, where we noted that individuals with CHIP had a higher overall mortality than individuals without CHIP, and that couldn't be attributed just to myeloid malignancies, which are relatively rare, but instead we found that these individuals had a higher rate of myocardial infarction and stroke than the general population. And that's even when adjusting as well as we could for known cardiovascular risk factors, including age, sex, body mass index, lipids, blood pressure, and smoking. And this finding was replicated in a number of additional cohorts. Importantly, these are cohorts that were very well phenotyped for cardiovascular disease, because they were designed in part for the study of cardiovascular disease, and that they were a high-risk population with many cardiovascular risk factors and many events. The effect sizes have been more modest when we look at lower risk populations, young healthy populations like the UK Biobank, but they are more robust when we look at populations with both better phenotyping and more cardiovascular risk factors. Another finding that has been extremely robust across many groups, including ours, is in murine models, in particular with TET2 knockout blood cells. And in these models, where the mice are fed a high cholesterol, high fat diet and are transplanted either with wild type or TET2 knockout cells, the inactivation of TET2 only in the hematopoietic compartment is sufficient to accelerate atherosclerosis in a mouse model. And you can see that in the top. This is a descending aorta, and you can see these oil red O stained atherosclerotic plaques are more common with TET2 homozygous knockout hematopoietic cells. In the middle, you can see the heterozygous knockout TET2 hematopoietic cells lead to modest increase in plaque formation and much less when the blood cells are wild type. This has been very reproducible across variations in diet and experimental design across many different labs. So the TET2 knockout really recapitulates this phenotype very, very well in vivo, providing a nice model to study TET2 mutant hematopoietic effects on inflammation. Now, one of the next questions is, what are the reasons for TET2 knockout cells to drive inflammation? And a finding that has, again, been quite reproducible in many studies is that there are a number of cytokines, inflammatory cytokines, that have higher expression in mice with TET2 inactivation in the hematopoietic compartment. This particular study graph is from a study where we were looking at gout, and we were injecting monosodium urate crystals into the peritoneum and then measuring inflammation in mice with and without TET2 inactivation. And if you look at the cytokines that are selectively elevated in the mice with TET2 inactivation, IL-1 beta is right at the top, along with CCL5, CCL22, and some others. But we see the same cytokines come up if we look at bone marrow-derived macrophages stimulated with LPS or a wide range of other inflammatory insults. And most originally, Ken Walsh's group, when they first showed that TET2 knockout mice have accelerated atherosclerosis, they found that inactivation of the NLRP3 inflammasome, which is upstream of IL-1 beta elaboration, reversed the pro-atherosclerotic effects of TET2 inactivation in vivo. So, number of studies show that the NLRP3 inflammasome and IL-1 beta in particular are elevated in IL-1 beta in TET2 knockout models. Now, in addition to the murine models, there's human data to support that TET2 inactivation elevates IL-1 beta. And this comes from the Top Med study, and this is a paper from Alex Bick, where they looked at 100,000 whole genome sequences from individuals and looked at who had CHIP, and the same mutations come up, led by DNMT3A, TET2, and ASXL1, the same age association we've seen always. But a number of these individuals also had cytokine data. And you can see in the right here that individuals with TET2 inactivation had a marked elevation in IL-1 beta. IL-6 was elevated in DNMT3A, TET2, and ASXL1, but IL-1 beta was particularly elevated in individuals with TET2 mutations. Different inflammatory cytokines were elevated in different CHIP models, or in individuals with different CHIP mutations, but IL-1 beta and TET2 were tightly linked. And this was particularly interesting in the light of the CANTO study, which was a large randomized placebo-controlled clinical trial of the IL-1 beta inhibitor canakinumab. And this was a study by Novartis. It actually met its endpoint, and that canakinumab treatment decreased cardiovascular events. And they went back and with a little over 3,000 individuals with available DNA for exome sequencing. They did exome sequencing and looked at who had CHIP, and then analyzed the effect of CHIP on the benefit from canakinumab. And you can see if you look at patients without CHIP in the upper left, there is minimal benefit to canakinumab, and the p-value was not significant. If you look at patients with CHIP, there might have been a little bit more benefit, but the p-value was still not significant with this sample size. However, if you selectively look at individuals with TET2 mutations, and again, individuals with TET2 mutations have been found to have higher levels of IL-1 beta, as well as mice with TET2 inactivation have higher levels of IL-1 beta. If you block IL-1 beta with canakinumab, these individuals have a huge effect. Over 60% decreased risk of major cardiovascular events in individuals with TET2 mutant CHIP compared to not having the TET2 mutations. And then the individuals with CHIP without a TET2 mutation also had relatively minimal benefit from, or no benefit at all from canakinumab. So all of this lines up that humans and mice with TET2 mutations have higher IL-1 beta, and blocking IL-1 beta can block the inflammatory consequences. Now, is it just cardiovascular disease, or do individuals with CHIP and MDS would have other inflammatory disorders? One approach that we took to this was led by Lachelle Weeks, and she used an extremely large data set using Medicare data and SEER data. SEER is the National Registry of Cancer Cases in the United States. and Medicare is the medical records, or the insurance program for individuals over age 65 in the United States. And she argued that individuals who develop MDS or AML likely have a precursor state of CHIP that precedes that myeloid malignancy by a certain amount of time. And that precursor state may predispose to non-malignant disease. And so she looked at new disease diagnoses in the 5 years prior to the development of myeloid malignancy and looked at whether that was higher than one would be expected compared to those who did not develop a myeloid malignancy. So looking at these 5 years antecedent to the diagnosis, she could look at 20,000 or so cases who developed MDS or CMML compared to a large control population. And just as we see with looking at individuals with CHIP, there is an elevated risk of cardiovascular disease, pulmonary disease, metabolic disease, bone and joint disease, but really strikingly, a marked decrease in the risk of neurologic disease led by a decreased risk of Alzheimer's disease. And that is held up now in a few studies and is really quite a striking finding, the molecular basis of which we still don't fully understand. If you look at the specific diseases, there's an increased risk of heart failure and atherosclerosis, COPD, chronic kidney disease, fatty liver disease or NASH, osteoarthritis, osteoporosis, rheumatoid arthritis, and gout. And for now, every one of these diseases, there is data for CHIP, that individuals with CHIP have a higher risk of incident diagnosis of these diseases. And now looking at cases of MDS or CMML, there's an increased risk of diagnosis of these diseases in the 5 years prior to diagnosis of the myeloid malignancy. All right, now looking at the association of CHIP and liver disease. This is actually both in CHIP and in the MDS study I just described, is really one of the diseases that has the highest effect size with an odds ratio of over 2 in many cases. And we looked at many different data sets here, including the UK Biobank, the Framingham Heart Study, the ERIC study, and looking at those as in a meta-analysis. And very consistently across many studies, there's a striking increased risk of chronic liver disease. You can see in this cumulative incidence curve in black, individuals with CHIP have a much higher risk with age than individuals without CHIP. It's about twofold prevalent, increased risk of both prevalent or incident disease. There's no association with fatty liver, only with fatty liver inflammation. So not NAFL, or non-alcoholic fatty liver disease, but an increased risk in non-alcoholic steatohepatitis or NASH. And then the downstream consequences of chronic liver disease, including cirrhosis. And that's a pretty big risk factor, even compared to major risk factors like morbid obesity. Now, in each of these cases now, different genotypes have different risks. And in this case, it is driven by particularly TET2 and JAK2. But first, on the upper part, showing that most of the risk is driven by individuals with large clones with a VAF of at least 10%. That has been true across all diseases we've looked at, that those individuals with a VAF greater than 10% have almost all the risk. Those with VAF less than 10% have a minimally increased risk of inflammatory disease. If we look at the individual mutations, DNMT3 mutations have minimal effect on inflammatory disease, whereas TET2 mutations have a very marked effect with an odds ratio of over 5 for developing fatty liver disease, and JAK2 mutations have a massive effect on chronic liver disease with an odds ratio of at least 17. That may be due to inflammation, but it also could be due to thrombosis, which is clearly associated with JAK2 mutations. And here, like many other inflammatory diseases, we can model this in mouse models with TET2 mutations. And here we can see that in mice fed a Western diet, meaning a high-fat, high-cholesterol diet, those with TET2 on the right, upper right, have these red reticulin stains indicating the development of fibrosis in the liver. Whereas if we take these mice and treat them with an NLRP3 inflammasome inhibitor, this fibrosis is markedly decreased. So just like with cardiovascular disease, decreasing the activity of the NLRP3 inflammasome can mitigate the inflammatory consequences of TET2 mutations. And then in closing, I wanted to note work that we've done on the prediction of outcome in individuals with CHIP. We did this in the UK Biobank in 500,000 individuals, with splitting that into a derivation cohort and a validation cohort, which performed very, very well. We first looked at what genotypes have what effects, and you can see that DNMT3A is by far the most benign mutation. Amongst individuals with CHIP, it is by far the lowest risk. And you can see here on the right, in green is the DNMT3A mutations. They're not completely benign. Having a DNMT3A mutation has a higher risk than individuals without a mutation for the development of a myeloid malignancy, but that effect is very small. Splicing factor mutations have a huge risk and are also among the faster growing clones. AML-like mutations like RUNX1 and IDH mutations also have a very, very high risk. JAK2 mutations have an enormous risk of progression, but many of the other mutations have a much more modest risk. And the top three, DNMT3A, TET2, and ASXL1, are relatively modest in their effects. So we can see that if you pull out the single DNMT3A mutations, the other mutations have a much higher risk. So we pulled together all of the features that we routinely collect clinically and that have been implicated, at least on some level, with risk of developing myeloid malignancy. And we did an unbiased approach, a recursive partitioning approach, to see which of these features are the most important for predicting the development of a myeloid malignancy in individuals with CHIP. And the most important feature was having a high-risk mutation. The second most important feature, amazingly, is the red cell distribution width, the RDW, which may be reading out some aspect of clone size, maybe reading out some aspect of inflammation or the residual state of the hematopoietic system, but is a very powerful predictor of poor outcomes. And beyond that, the number of mutations, the mean cell volume start to matter. But you can start to see that the risks start separating quite dramatically. With on the right in red, these individuals have over 50% chance of developing a myeloid malignancy in the 10-year or so follow-up. And in the left side in green, individuals with extremely low risk of less than 1% risk of progression. We assembled this into a very simple scoring system that is very intuitive. Having a single DNMT3A mutation is very benign. Having a high-risk mutation, the number of mutations, varying allele fraction, red cell distribution width, MCV, cytopenias, and age are the major features, and have just a very simple scoring system adding those up. And when we do that, we can separate into three categories: low, intermediate, and high risk. Low risk have about a 3-fold increased risk of developing a myeloid malignancy. Intermediate risk have about a 35-fold risk, and the high risk have about a 350-fold increased risk of developing a myeloid malignancy. And if you look at the cumulative incidence curves, though low-risk individuals, very modest increased risk, really probably do not need to be followed in our clinics. Intermediate risk have a more intermediate risk, and the high risk have an extremely high risk. And this is extremely important because 90% of individuals with CHIP are in the low risk category, and it would not be possible for our clinics to follow all CHIP patients, but those 90% with low risk probably need no follow-up in a specialized clinic. In contrast, those with high risk have such a high risk that we could probably start to justify interventional clinical trials to, with at least very benign agents to decrease the risk of progression. And moreover, this correlates with overall survival. So low risk barely budges the overall survival of individuals. Intermediate risk more, and the high risk individuals have only a 50% 10-year survival, which is much, much worse than the low risk group or the no chip group. And so that really speaks to both the malignant and the non-malignant causes of mortality in these individuals, because most of these individuals are dying not with a myeloid malignancy, but from other causes. So in summary, wanted to note that CHIP is common, it's age-associated, it's associated with hematologic malignancy, overall mortality, cardiovascular disease, and other inflammatory diseases, that the inflammation is associated with elevated expression of inflammatory cytokines, and that in several cases, that phenotype can be reversed with NLRP3 inhibition. The clonal hematopoiesis risk score predicts risk of myeloid malignancy and overall survival in individuals with CHIP, particularly individuals with splicing factor alterations are high risk. Multiple genetic abnormalities, size of the clone, altered CBC parameters all contribute to the risk. And this is very collaborative risk work. I've really emphasized a lot of work that was led by Lachelle Weeks, who is now an independent investigator at the Dana-Farber as of the last few months. And I'd be very happy to take questions live. Thank you very much for your attention.
Thank you very much. Great talk as usual. So 3 people are already standing.
Hi, Ben. This is Moshe Mittelman. How are you? It was wonderful. 2 questions, quick question I will try. Number 1, since you contributed so much, and today we know to identify patients, or I should say individuals, with pre-MDS states. What is your answer to the regulators and the policymakers? Is it worth to detect it? I mean, we have nothing to take care of it except for kind of follow-up, and we find it difficult to convince, you know, the insurance company, the public policymakers to make it, number 1. The second question is, maybe considering your data, the treatment with aspirin that we believed for 20, 30 years that it's anti-aggregating and protects patients from becoming cardiovascular patients, maybe again, it's the anti-inflammatory treatment, and maybe we should increase the dose to anti-inflammatory dose. What do you think?
Those are fantastic questions. I hope you can hear me okay.
Yeah.
So first, is it worth diagnosing these individuals, and should we see them? Since we don't have an intervention, we're certainly not recommending anybody be screened for this, or that anybody should be treated with any therapy outside of a clinical trial. We did collaborate on a study of patients actually with breast cancer who were tested for CHIP, and we assessed this sort of psychological toxicity of the diagnosis. And most patients were thankful for that we were looking for everything, you know, possible that could improve their care. But a small minority had a very negative reaction and said, you know, why are you diagnosing me with something that you're not going to do anything about? And this is just stressing me out and not helping anything. So we do need to be cognizant of that. And we wouldn't screen anybody yet. However, just like other malignancies that we don't treat in the initial stages, plenty of low-risk malignancies, prostate cancer, CLL, even low-risk MDS, where there's less effective therapies. This is the diagnosis of MDS is a continuum, and some of these high-risk patients are really starting to get closer to the risk of MDS. And indeed, some of the high-risk patients may skip low-risk MDS and become high-risk MDS relatively quickly. So it's certainly something to study, if not screen for at this stage. And aspirin is a very interesting question. We haven't studied this in any models yet. There's no human data that supports aspirin to lower mortality in individuals with CHIP, but what the cardiologists who see patients in our CHIP clinic tend to do is basically maximize preventive therapy, whether it's statins, antihypertensives, and aspirin for lowering risk of cardiovascular disease at least. And what we're going to do for the inflammatory component, we'll see.
Hi, Ben. It's Toshio speaking. Thank you very much for your wonderful review of our chip. I have one question. So, from your data, we now know that short life expectancies of chip people largely depends on coronary heart disease or strokes. But today you showed the worst life expectancy is for the chip with splicing machinery, splicing mutations. But splicing mutation people don't have any risk for coronary heart CVDs. So what is the cause of the shorter life expectancy of chip with splicing factors?
That's a great question. I don't know that we've looked specifically at the chip with splicing factors and their risk. They do have a very high risk of progression to MDS,
Yeah, I know.
and so it may be that they are dying of MDS. The selection of the high-risk mutations was on the basis of progression to myeloid malignancy, not on the basis of overall mortality. We could have developed a model based entirely on mortality, but our model was really based on myeloid malignancies, and then we looked at overall survival, and so we could go back and look at that. I also think that the outcomes vary in the different cohorts based on the different risk factors. Some of our early studies had been in cohorts of individuals that were really designed to study cardiovascular disease, and patients had many cardiovascular risk factors that were very well annotated in the cohort, and the risk of secondary cardiovascular events was very, very high, and cardiovascular mortality. The UK Biobank is the opposite. It's a relatively young, healthy cohort, and so there's much less cardiovascular death compared to those other cohorts. But still, the minority of the overall mortality, to the extent that we can tell from these large cohort studies, was due to the diagnosis of MDS or other myeloid malignancies.
Okay, thank you very much.
So, Seshaga, so beautiful talk as always, and thank you so much for your attendance and online, even in the midnight in Boston. So thanks so much. So my question, two questions. So first, related question. First question is that you show the significant association between CHIP and non-malignant diseases. For example, chronic liver disease is very high risk. So my question is, which is the cause and which is the result? Or this is a chicken and egg problem? This is the first question. And the second question is, do you have any chance to compare the genetic predisposition locus for CHIP and chronic liver disease? So CHIP has some German variant is associated with CHIP, and other variant associated with chronic liver disease and rheumatoid arthritis and so forth. So there's any overlaps between those predisposing locus or not? Do you see a chance to do that? So
those are great questions. Thanks, Eishi. And thank you for inviting me. I wish I could be there. So your first question was about causality of the inflammation, whether the clone drives inflammation or the inflammation drives the clonal expansion, or both. And I don't think we totally have the answer. We do know that at least in model systems, the introduction of the mutation is sufficient to cause inflammation in macrophages and in neutrophils. So having these mutations in those cells make them more likely to become inflammatory, activate the NLRP3 inflammasome, increase IL-1 beta, IL-6. So that's sufficient. In addition, that inflammation may drive the clone. There may be even more complicated feedback of the clones being resistant to inflammation and gaining a competitive advantage with the normal cells. But I think that is not entirely clear. Clearly, also in animal models, induction of inflammation can lead to clonal expansion. So both have been demonstrated in model systems, and how that plays out in a human isn't entirely clear yet. But it's one of the great questions. Your question about germline polymorphisms in the liver disease is extremely interesting. I don't know about the individual polymorphisms, but we worked with Pradeep Natarajan and other geneticists to do Mendelian randomization studies on the effect of CHIP and liver disease. And the Mendelian randomization studies did show or indicated a causal relationship between the CHIP and the liver disease based on those germline polymorphisms. So the fact that the effect size was reasonably large, that we had a very large number of individuals, and the clear inherited risk factors that we now know for CHIP enabled us to do a Mendelian randomization study for the chronic liver disease.
Okay, so you have a lot of data about the genetic predisposition for rheumatoid arthritis and many diseases. So yeah, thank you so much.
Hi Ben, it's Elsa. Very nice talk. Quick question about what are your thoughts on the applicability of the clonal hematopoiesis risk score, specifically in the cancer population? So the cancer, we often, more and more with cell-free DNA analysis, CHIP is detected in this population, but often those patients have may have post-treatment cytopenias or a different representation of CHIP mutation. So do you think it applies, or should other tools will have to be developed?
I think Lachelle is actually working on that right now. And as you know, this is a particular interest for all of us who work in cancer centers, because that's the population of patients that we see are the individuals who've received cytotoxic chemotherapy and radiation that may develop CHIP. And so Lachelle is looking at that right now, and I think others may be as well. So that's an extremely important question, because that's, for many of us, the patients who end up in our clinic are patients who've had treatment for cancer. So both, I think, the questions about whether there's any situations where therapy might be modified on the basis of CHIP, or how we deal with our cancer survivors who have CHIP. It may be that the CHRS is perfectly fine, but we're going to try to make sure that there aren't other features that are more applicable in this population. Great question.
Thanks.
I have a short question. I noticed that the clonal hematopoiesis having p53 mutation have relatively low effect on the development of myeloid malignancy. So do you have any comments on that?
We scratched our head about this over and over and didn't have a perfect solution to this. P53 mutations, actually both in animal models and in humans, can sit there for a long time and have very little clonal expansion and not an aggressive course. However, as we all know, when a malignancy does occur, maybe a karyorrhexis or some major event, the clone can be very aggressive and ultimately result in the types of MDS that have the worst overall survival and the worst response to therapies. So we ended up feeling like we couldn't include P53 as a low-risk mutation, even though in this particular cohort, P53 mutations were not associated with a high overall risk of getting a myeloid malignancy. But we know that if they do get a myeloid malignancy with that P53 mutation, it's going to be very bad. So we kind of appointed it as a high-risk mutation without having it be indicated as a high-risk mutation in this data set. But I think that is what happens in animal models and in humans, that those clones can sit there for a very long time without progression and then progress very rapidly. But based on the outcome of patients with p53 mutant myeloid malignancy, we ended up calling it a high-risk mutation. That's a great question.
Thank you very much. So if any further questions, thank you very much, Ben, again. The next speaker will be Masataka Taguchi from Nagasaki University. He will go and talk about atomic bomb survivors.
So thank you for introducing me, Dr. Chiba. And good afternoon, everyone. My name is Masataka Taguchi from Nagasaki University. First of all, I'd like to thank organizers for giving me this opportunity to present our recent work titled Clonal Hematopoiesis in Nagasaki Atomic Bomb Survivors. I have nothing to disclose. So ionizing radiation is a very established risk of DNA damage and cancer development. The lifespan cohort study of atomic bomb survivors showed that atomic bomb radiation is a risk of many solid cancers, as shown here. So for example, here, for all solid cancers risk, so the excess relative risk is 0.5. And for bladder cancers or other breast cancers, the excess relative risk is 1.2 or 1. But the ionizing radiation, it causes many solid cancers among the survivors. The cohort study also showed that A-bomb radiation is a long-lasting risk of AMR, even more than 50 years after the bombing. The excess relative risk is increased by the dose-dependent manners, and this risk is lasted after the bombing. So for example, the survivors exposed by A-bomb radiation at 10 years old have very high risk after 5 years after the bombing. And then this risk is so even after 50 years after the bombing. We also showed that A-bomb survivors have a higher risk of MDS 40 to 60 years after the bombing. The excess relative risk per gray is 4.3, and the risk is increased with dose-dependent and exposure distance-dependent manners. We further showed that MDS among highly exposed survivors have unique genomic alterations, such as less frequent mutations in the genes involved in DNA methylations and higher frequency of deletion 11q. The frequency of TP53 mutations are almost same between the groups. So here we compared the highly exposed survivors as shown in PE. So the median exposure distance is 1.1 kilometers. The estimated radiation dose is 1 gray. And we compared this group to the distally exposed survivors. The median exposure distance is 3.4 kilometers. And we also observed that relatively higher frequency of deletion 20q in highly exposed survivors. Based on these results, we hypothesized that A-bomb radiation caused DNA damage in hematopoietic stem cells, and these damaged HSC could survive with clonal selection and acquired more DNA damage during the aging, and resulting in clonal hematopoiesis with distinct features and higher incidence of myeloid neoplasms. To address this, we performed whole exome sequencing of 81 ABOM survivors and 20 unexposed individuals without hematological malignancies. The median age is about 70 years in both groups, and there are more females in ABOM survivors. And all ABOM survivors were exposed by ABOM radiation within 1 kilometer from the hypocenter at the age of less than 20 years. 3 cases of ABOM survivors developed hematological malignancies during the follow-up period of 13 years, and there's no cases of hematological malignancies in the unexposed individuals in the 3 years of follow-up. We also assessed the longitudinal changes of blood counts in the ABOM survivors for a total of 26 years, 13 years before and after the sample collection. Here, I'd like to briefly explain the method of variant detection and copy number analysis. So we sequenced peripheral blood for all samples and obtained sufficient depth of coverage. And we performed variant calling and filtering as described here, and identified 670 putative somatic variants with variant allele frequency of more than or equal to 2%. We also performed copy number analysis using whole exome sequencing data and identified somatic CNA as described here. We further selected these 171 genes as candidate drivers to assess the impact candidate drivers or non-candidate driver gene mutations on clonal hematopoiesis. These genes had been targeted in these 3 previous studies about CHIP. So overall, ABOM survivors tended to have more variants comparing to unexposed individuals. However, the frequency of the cases with candidate driver gene mutations are almost same between the groups. When we look at the number of variants, so more variants were acquired in the cases with candidate driver gene mutations in both groups. We also looked at the variant allele frequency of candidate driver gene mutations and non-candidate driver gene mutations, as shown here. The gray color is non-candidate driver gene mutations, and red color is candidate driver gene mutations. And as you can see here, candidate driver gene mutations are found in major clones, and its clone size was relatively larger in ABOM survivors comparing to unexposed individuals. We also looked at the cases without candidate driver gene mutations. The clone size is getting larger if the cases have more variants. And interestingly, the clone size is significantly larger in ABOM survivors, even in the cases without candidate driver gene mutations. Furthermore, we observed 3 cases developed myeloid malignancies such as MDS and ET 3 or 12 years later, even though these cases had not possessed candidate driver gene mutations at this point. We further looked at the longitudinal changes of blood counts and to assess the impact of candidate and non-candidate driver gene mutations. And we compared these 2 groups to the individuals without any mutations or CNA. For white blood cell and platelet counts, there's no apparent effect of candidate or non-candidate gene mutations on the longitudinal changes. However, hemoglobin levels declined over time in ABOM survivors, especially in the cases with candidate driver gene mutations. Furthermore, hemoglobin levels significantly declined if the cases possessed both candidate or non-candidate driver gene mutations and CNA, as you can see here, suggesting that so additive or synergistic effect of candidate or non-candidate driver gene mutations and CNA on erythropoiesis. We then looked at the details of candidate driver gene mutations. So the frequency of DTA mutation was relatively lower in ABOM survivors. But when we looked at the genes categorized by the functions, there are no apparent differences between the groups. We also analyzed the copy number alteration in ABOM survivors. So deletion 20q were frequently observed in ABOM survivors, which was about 10% of the cases, followed by deletions 5q, 11q, aberrations in chromosome 2, and deletions of whole chromosome 19. We looked at the clonal self-fraction of these non-candidate and candidate genes and deletion 20q. So deletions 20q are found in major clones accompanied with or without candidate driver gene mutations, suggesting its clonal dominance in ABOM survivors' clonal hematopoiesis. Lastly, we compare the frequency of deletions 20q of ABOM survivors with the other unexposed Japanese populations. The frequency of any CNA or multiple CNA were almost same among the groups. However, deletions 20q were highly accumulated in ABOM survivors, suggesting it's an important role of deletions 20q in ABOM survivors' clonal hematopoiesis. In summary, clonal hematopoiesis among ABOM survivors showed unique features such as larger clone size, even in the cases without candidate driver gene mutations, and high accumulation of deletions 20q. Candidate driver gene mutations and CNA had a strong cooperative impact on longitudinal decline in hemoglobin levels among the survivors. Deletions 20q are found in major clones, which could have contributed to clonal selection and expansion of CH during the aging after the bombing. So finally, I'd like to thank all the collaborators, all the participants, and atomic bomb survivors. Thank you very much for your attention, and I'll be happy to take any questions.
Thank you very much, Dr. Taguchi, for the wonderful talk. Okay.
I'm Naya from the University of Tokyo. Thank you for your wonderful talk. You showed that 20q deletion is commonly observed in atomic bomb survivors with clonal hematopoiesis. Is it compatible with the genetic abnormal profile of the atomic bomb-related myeloid malignancy? This is the first question. And do you have the chance to observe the change of clonal hematopoiesis size, especially for the patients who showed decline in hemoglobin level?
So thank you for the question. The first question is, so whether some genetic abnormalities, so especially genetic abnormalities in myeloid malignancies in MDS, among atomic bomb survivors, which are particularly observed in deletion 20q, right? So we have not studied yet, but in our previous genetic study of MDS among ABOM survivors showed that a relatively higher frequency of deletion 20q comparing to so lower or unexposed individuals. So I think the deletions 20q are so accumulated even in the MDS cases among atomic bomb survivors. And the second question is, so we have not looked at the clone sites of so relating to the decline of hemoglobin level yet, but I think it's a little bit difficult because there's no difference at the sample correction in the hemoglobin levels. So we may be able to approach this by so classifying, for example, higher buff group and lower buff group, and then looked at the decline of hemoglobin levels.
And do you have the chance to observe, check the RDW value of survivors?
No, not yet.
Not yet. Okay, thank you.
Thank you very much for your talk. I really enjoyed it. So I have a question that is more curiosity. I noticed like you have this enrichment in del20q, right, in your atomic bomb survivors that developed this MN. So my question is sort of like I'm reminiscing. In Schwachman-Diamond syndrome, the lesion 20q is a somatic gene rescue mechanism because of the presence of EIF6 in the region that is deleted. So I'm just trying to speculate. Is there something that we don't know in the ontogenetic mechanisms that lead to ontogenesis of myelodysplastic syndrome in atomic bomb survivor, and perhaps what we are seeing as enriched, that is the deletion 20q, is a somatic genetic rescue mechanism that like the bone marrow is like trying to excogitate to try to somehow overcome the fact that we are obscure in this moment, like we don't know in this moment. What do you think about it?
Yeah, that's a great question. And so we don't know the answer, but I expected that, so actually indeed, ABOM survivors have had so atomic radiation exposure. So the hematopoietic stem cells is declined at that time. And then, so to recover the blood cells, the hematopoietic stem cells so suffer that conditions, so emergency conditions. And then such deletion 20q, so 20q deleted hematopoietic stem cells could survive that emergency condition and survive and expand during the aging, and then so acquire other driver mutations of myeloid neoplasms, and then resulting in myeloid malignancies. But it's speculation.
Hi, Masan. So thank you for your talk. To follow up on the previous discussion, I wanted to know whether you are aware of the comorbidities and inflammatory status of all the people you have been analyzing in this cohort.
So now we are looking at the comorbidity for these participants. But in general, so ABOM survivors, especially so highly exposed survivors, have inflammatory conditions comparing to the non-exposed individuals. So maybe so these clonal hematopoiesis can relate to that inflammatory conditions.
Thanks.
Well, the del20q frequency at 10%?
Yes.
The cohort could be surprising. So, or is it possible to consider any radiation biological point of view to say something about that?
So it's a difficult question, but I don't know the answer. But so most deletion 20q are internal deletions in long arm of chromosome 920. So if the A-bomb radiation causes double-strand break on long arm of chromosome 20, and then such double-strand break cause such internal deletions, then survive during the aging. But that is my speculation.
Thank you. Any other questions? Well, we have several minutes. So, okay, perhaps this is very difficult to answer, and perhaps this is not belong to science, but some tale. But we understand in Hiroshima there was increased frequency of CML, but in Nagasaki maybe not. So, is there any tale or story spoken about the differences between the two A-bombs?
In general, the landscape is different between Hiroshima and Nagasaki. Nagasaki has a lot of mountains and the narrow space of flat areas, but Hiroshima has a lot of flat areas. So I think the survivors could be exposed more radiations in Hiroshima because of such flat areas. But Nagasaki, there's some shadows, and then so they are protected, I think. But it's difficult.
Okay, thank you very much. So if there is no further question, then we'll close the session. Thank you very much, Dr. Taguchi.